In this clinical explainer, we're taking a close look at a single-center study on pediatric microsurgical free flap reconstruction for the head and neck. We'll be exploring the study's really novel approach to assessing just how effective these treatments are, using a method that goes way beyond simple flap survival rates to give us a much more complete picture of patient outcomes.
So here's how we'll break it down. First, we'll start with the study's main conclusion. Then we'll get into the methodology, how they did it. After that, we'll analyze the outcomes, investigate some key variables, and finally, we'll discuss the broader context and what it all means.
All right, let's begin with the principal takeaway from all this research. What did the authors find?
The core finding of the study is that this very complex type of surgery is in fact both safe and effective for children. Now, the way they reached this conclusion is what's really interesting here, especially because, as you're about to see, some of the outcomes, like flap survival, were a bit different from other reports. The data really makes a strong case that overall success is about so much more than just the technical viability of the flap itself.
So, to really understand that finding, we first have to look at exactly how the study was conducted. Let's dig into the methodology.
Okay, so the analysis was based on a retrospective look at 54 procedures that were done at one specialized center over a 5-year span. The cohort they looked at included 46 patients, and the age range was huge, from 16 months all the way up to 18 years. And they were dealing with a whole host of challenging conditions, from tumor resections to trauma.
Now, here's a really key innovation in this study, the treatment effectiveness score. Traditionally, success is often judged by one single thing. Did the flap survive? This composite score, though, provides a much more holistic view. It integrates viability with how the recipient site healed, the impact on the donor site, and, crucially, functional outcomes. It's a pragmatic framework for a much more complete assessment.
So how does the scoring actually work? Well, it's pretty straightforward. You start with a perfect score of 100, and then points get deducted for specific complications. It's really important to notice the weighting here. A functional impairment, like trouble swallowing or breathing, gets a 20-point deduction. That's double the penalty for a wound complication, which really reflects the greater clinical impact on the patient. And of course, a score of 0 means total flap loss.
Okay, with that scoring system in mind, let's turn our attention to the specific results that came out of this cohort. What do the data show?
The overall flap survival rate in this series came out to 76%. What that means is that total flap necrosis, or complete failure, happened in 14 of the 54 reconstructions. Now, we're going to put this number into context with other studies a little bit later.
This chart gives us a more detailed look at the outcomes at the recipient site. So on top of those 14 cases of total flap loss, partial complications occurred in about 37% of the procedures. The most common issues they saw were wound dehiscence. That's when the wound edges separate, and some marginal flap necrosis.
And this is where the story gets much more nuanced. Despite those flap complications we just talked about, a remarkable 80.4% of patients achieved a full restoration of function. We're talking across 4 critical domains: swallowing, mastication, breathing, and mouth opening. This is a really critical finding. It suggests that even when some minor healing issues pop up, that primary goal of functional recovery is still largely being met.
On top of that, the impact on the donor site, the area where the tissue was taken from, was minimal. Complications there were pretty infrequent, happening in just over 5% of cases. This finding really helps reinforce the overall safety profile of these complex procedures in kids.
The study also dug a little deeper to see how outcomes might be affected by 2 pretty critical factors: the patient's age and just how complex the defect was that they were trying to reconstruct.
When you look at this plot of the treatment effectiveness scores across the different age groups, it's quite revealing. There was no statistically significant difference in the outcomes, whether the patient was under 5 or over 15. This really supports the idea that it's feasible to perform microsurgery across the entire pediatric age spectrum. Now, the authors do point out that the statistical power here is limited, but it's an important finding nonetheless.
The analysis did, however, find something else, a very specific pattern of failure. The flap losses weren't just random. They tended to cluster in a particularly challenging subgroup. We're talking about reconstructions involving the maxilla, especially in patients who had bilateral clefts. This is an important clinical insight. It highlights that the type of defect might actually be more predictive of the outcome than the patient's age.
So, to interpret these results properly, we have to put them into a broader clinical and research context. And of course, we need to acknowledge the study's own limitations. Okay, let's come back to that 76% flap survival rate.
It's important to note that this is in fact lower than the greater than 90% rates that are often reported in other contemporary series. The authors suggest this might be due to a few factors, like the high complexity of their cases, many of which involved congenital deformities, and also the natural learning curve that comes with these kinds of advanced procedures at a single institution.
The authors are also very transparent about the study's limitations. It's a retrospective analysis, it's from a single center, and it has a very diverse patient group. But most importantly, that treatment effectiveness score, as innovative as it is still an exploratory tool. It's not a validated patient-reported outcome measure, so we have to interpret its results with some caution.
Ultimately, this study's use of a pragmatic composite score really pushes the field to think beyond just whether the blood supply to the flap was maintained. It shows us that satisfactory functional recovery and low donor site morbidity can be achieved even when flap survival rates aren't perfect. And this leaves us with a really important forward-looking question. How can scoring systems like this be refined, validated, and standardized so we can better capture the true measure of success in this challenging field?